right, so I think we can go ahead and get started while people are trickling in. My name is Brett Sperry. Again, I'm a cardiologist at St. Luke's Mid-America Heart Institute here in Kansas City. I want to welcome everyone to the last day of this week-long tour of amyloidosis that we've been calling the Virtual Amyloidosis Symposium. Here with me, my co-host, Dr. Saeed from cardiology. He'll be speaking first, as well as Dr. Shahzad Raza and Farah Qasser from hematology at St. Luke's Cancer Institute. Some housekeeping again, everyone keep your audio on mute. We'll have the speakers stick to their time slots, which you see here. And if speakers finish early, we can ask some questions before the next talk. If not, we will do question and answer at the end. And feel free to ask any questions in the chat box to everyone in the meeting or personally to me, and then we can use those to discuss more at the end. So with that, I will introduce my colleague, Dr. Ibrahim Saeed, who is going to start things off today. He's an associate professor of medicine at the University of Missouri, Kansas City School of Medicine, co-director of cardiac amyloidosis program here at St. Luke's. He started our cardiac MRI program here 8 years ago when he came from Washington University in St. Louis. He's been an excellent colleague and has really helped plan and orchestrate and execute this meeting. Dr. Saeed also co-hosts a meeting in Kansas City that we put on, which is called The Heart, which is in its 50th year now, and we may be moving to an online format similarly in the 50th year anniversary because of coronavirus concerns. But during this meeting, Dr. Saeed really likes to look at people's CV and find the most interesting thing on it and then mention it during their introduction. So I was able to get a hold of his CV, and I noticed that he keeps a Cayman Island medical license active. And so maybe during the question and answer session, we can ask him what he has planned to do with this license, because it may be something we're all interested in. So Dr. Saeed, again, will be speaking about echocardiography and amyloidosis with the title of Straining to See the Fibrils. Take it away.
All right. Let me just share my screen here real quick. Well, thank you all. One second. Let me share my. And can you guys see this? Or let's try this now. Is it in presentation mode? Can you see it? Perfect. Well, it's an honor to be here. It's an honor to speak. Actually, it's quite humbling because Brett has taught me a lot, but to be sharing the virtual stage with Sharmila and Marianna, who have taught me so much about amyloidosis from all their nuclear conferences and MRI conferences. So I'm quite humbled to be in the same platform or venue with them. But let's get started. I have really none financially relevant. I have done some theoretically some speaking work for Pfizer, haven't really yet, but I do love all cardiovascular imaging. I want to give a second to talk about the Mid-America Heart Institute, just to give a shout out. You know, it was the world's first heart institute. It's where the first infarct angioplasty happened. It's home of the red dress, home of the Kansas City Cardiomyopathy Questionnaire. It's a high heart transplant place. It's got the usual structural, valvular, congenital. This was fun to set this up with Brett, the cardiac amyloid clinic, the autonomic clinic, busy clinically and nuclear wise. And I was cardiologist number 40 out of either 65 to 70. It's hard to count how many cousins you have. And it's just one happy family. So I wanted to start off with a little bit of poll so I can sort of gear my talk to who is in the audience. So I think, Becca, if you're on with VisionMinder, would you mind just setting up the poll to see if it's there? Please click to see what is your specialty. So a lot of cardiologists, some hematologists, a lot of others, nephrologists, neurologists, internists, radiologists. Okay, so there are some things in here that I'm not as smart as hematologists that I will do my best with, and some things that may be very basic to some cardiologists, but I think we'll all learn together. These are the results so far. And I have to close this. All right, let's get started. Action. So the goal of today is to review the echocardiographic features that may lead to the suspicion of an underlying infiltrative disorder, such as cardiac amyloidosis, and to recognize the role that echo can play in the management of these patients. So there are three roles of an echo. It can lead to the diagnosis, it sure as heck aids in the management, and it also suggests prognosis. So as a cardiologist, there are many things that show up in my office. Everyday cardiology is common things: chest pain, shortness of breath, edema, AFib. Sometimes we have this idea of diastolic heart failure, lightheadedness, syncope. And I'm going to explore some of this and help you show how an echo may help you decide, gosh, maybe this is amyloid. So I don't need to really review a lot of this because my predecessors have already done this during this week. What I'm really focused on is the heart for this first part of this session. And there's really, these are the proteins that are involved. And let me go a little bit more through this. The biopsy often shows either light chain deposition or transthyretin deposition. And when you have a little bit in your heart, you have some that lights up in your MRI. And when you have a lot of it shows up on your biopsy. Now, this is something that if you have enough of amyloid, you can infiltrate both ventricles. And initially, it turns out that you have a restrictive heart failure. Later on, you may have a systolic heart failure. Sometimes you can have coronary microvascular dysfunction as a cause of chest discomfort. Sometimes these fibrils can infiltrate the atria, and they can be arrhythmogenic. Sometimes they can be thrombogenic, and we'll talk about that. And sometimes you can get a neuropathy. Well, all these things that we see here can easily be involved with the common complaints we see in a cardiology office: the chest pains, the shortness of breaths. Sometimes when we order an echo to evaluate this stuff, we're lucky enough to see this classic example of an echocardiogram, which is this biventricular hypertrophy, biatrial enlargement, a really thick, sometimes bright septum. Sometimes you get a thick atrial septum, a little bit of a pericardial effusion. If you're lucky, you get an S prime or a systolic tissue Doppler velocity that's low, and then you get this cherry red spot. Sometimes the EKG is helpful and sometimes not. In the same example, this was the EKG earlier on, and several months later, this is where the voltage went. It just disappeared. So these are the take-home points 1 and 2. LVH in the absence of hypertension may suggest an infiltrative cardiomyopathy. We have drilled this down with our colleagues in the echo department that please, if you see LVH, or quote unquote LVH, because it's really not a thick muscle, right? It just looks thick. But LVH in the absence of hypertension may suggest an infiltrative cardiomyopathy. Please look at the blood pressure. And you can see the percentage of the times it's seen in different types of amyloidosis. And the other thing we often ask people to do, especially when you're reading EKGs, is LVH on echo without voltage on an EKG may also suggest an infiltrative cardiomyopathy. So in my training, almost a decade and a half ago, not quite, but I came across a couple of different patients. This is a patient that I was consulted on as a brand new attending that had a non-sustained ventricular tachycardia after back surgery. And I thought the echo looked pretty bright, but because of the NSVT, we ended up getting an MRI, and it had this kind of pattern that I'm sure Dr. Fontana will probably bring up. But this particular pattern then led to an endomyocardial biopsy, which showed this waxy, lardaceous, pink stuff that was mildly green on polarized light. And then this other patient had a stress echocardiogram done that happened to look bright. I didn't think it looked very bright, but the person who was reading stress echoes that day was a famous bird watcher, and I tended to trust his eyeballs. And so this patient got an MRI, and it looked like this, and it was even brighter on the polarized light. Looking back at this patient, he didn't have a very thick tongue as I could appreciate it. I didn't think he had the shoulder pads on. I had read Dr. Falk's papers and images many times before, and I was completely unimpressed that there was low voltage on his electrocardiogram. So this one lesson taught me quite a bit. That this was my take-home point number 3. You all are famous, know the famous phrase, all that is gold does not glitter. I have learned that all that is bright and sparkly is not amyloid. That in the era of harmonic imaging, almost everything looks bright, and I just don't think it is very reliable to count on. So this is something that I have learned from Dr. Dorbala in watching many of her lectures. And and I'm going to try to share what I've learned from her. So there are two flavors of amyloid in the heart, in my mind. There is the AL, often associated with plasma cell dyscrasias, which we've heard about all week long, which is associated with secretion of immunoglobulin light chains and can be systemic amyloidosis. And then there is this senile or wild type transthyretin, which is really a normal amino acid sequence, but is just deposited, it's gone wild. And it often results in predominantly a cardiomyopathy. And then you have this familial mutant transthyretin, which is this abnormal sequence which produces an unstable transthyretin, and it causes a familial cardiomyopathy or possibly polyneuropathy. Now, it took me forever to remember and separate these three out, so I came up with a mnemonic that has helped me, and hopefully it'll help you. And I think of ice cream. Either the chocolate, what was once considered to be the dark prognosis, and then the lighter prognosis, right? So here is, I think of the white-haired old man, and here is that family that has red-haired children all the time. The red hair keeps popping up. So this is how I remember with Neapolitan ice cream, the different types of amyloid in the heart. I'm going to show you a case of a next case here. This is a Jamaican lady, a woman, who presented with dyspnea and syncope. This is when I first got here, and I was struggling with an MRI program, and I was getting referrals. So this is a 44-year-old Jamaican woman, transferred. 8 months prior, she had increasing fatigue and dyspnea. With that, she got an echo, and it was normal 6 months ago. But a month ago, her EF was really low. And then the day before transfer, she woke up, she had chest pain, chest tightness, she was short of breath, nauseated, sweaty. Her cousin found her, woke her up, she was dizzy, not really confused, just dizzy. And then EMS came and found her that she was in VTVF. This is her electrocardiogram, and it's first degree AV block, anterior fascicular block, lack of R-waves across the precordium. And this was her outside nuclear stress test that showed this defect inferiorly. So we start off with an echocardiogram here, and what you will see here is that you have this thick, meaty ventricle. Actually, they're both thick, and despite being such a thick ventricle, it's just really not moving very well. So this is 2011. We did what we had. We got an MRI, and this is me struggling with a 10-year-old scanner 10 years ago. So this is what our late gadolinium pictures look like. And we see that where the walls are not moving very well, there is this late gadolinium enhancement. I don't mean to take away from Marianna, but this is things that I've learned from her. So she had an anion gap of 11, a globulin gap that was normal. Her SPEP was unremarkable, but her light chains were markedly elevated. And so she was found to have amyloidosis, endomyocardial biopsy, found to have lambda, bone marrow, and then we went on to have this diagnosis. Now, AL can have, as you all know, cardiac involvement, often 40-year-olds or above, and the involvement that you see at half the time is heart failure, edema, ascites, pleural and pericardial effusion. So if you're reading an echo, you have to be attuned to this. And surprisingly, despite the high tissue Doppler, pulmonary edema is felt to be less likely. I'm not going to focus on small vessel disease, but sometimes you can have pericardial deposits that lead to a pericardial effusion. You have the increased risk of thromboembolic events, and then, of course, there's a neuropathy. Now, sometimes they pass out, as did this woman. That was her presentation, was syncope. And finally, she had to syncope before somebody realized what was going on. So sometimes we worry about over-diuresis, and I am cognizant of Dr. Wittel's talk about how maybe you don't diurese enough. Autonomic neuropathy, ventricular arrhythmias, or just a lack of cardiac output. And we're going to talk about this for a little bit. So there are a lot of non-cardiologists out there. And I want to explain a little bit about what diastolic dysfunction is. So what is diastolic function? As you all know, the heart doesn't actively contract, it actively relaxes. This is an excuse I say often to my wife. What are you doing on the sofa? I'm actively relaxing. So this is a normal diastolic function. When the valve first opens up, there's this early wave of blood rushing in, and then a little bit of atrial kick. That is, the atria primes the pump. But as your ventricle gets stiffer, this becomes less active relaxation, and we rely more on the atrial kick. And eventually, the velocities are so high that there's a quick rush in and quick rush out because the pressures are so high. So this is like the progression of diastolic dysfunction. Sometimes you have a lower stroke volume, which we'll talk about, and sometimes you're lucky to have this longitudinal strain. So let's look at this echocardiogram a little bit more. You know, as I said, I'm not impressed with the sparkly myocardium, but I did mention that both ventricles are very thick. It's thick with a smaller cavity. Sometimes you're lucky enough to see really large atria and a thickened atrial septum. Sometimes you have some pulmonary hypertension, a PA pressure of 40 to 50, which is usually attributed because it's transmitted backwards from the high left atrial pressure. And of course, we talk about the restrictive diastolic dysfunction, that tall E wave that we talked about. And then luckily, sometimes we get this nice strain pattern here, this cherry on top strain pattern. Now, what is this trying to show? This is trying to show that, gosh, this apical segment is moving better than the basal segments here, right? And this movement sometimes can be seen in other pathologies we talk about. One can imagine if you had bypass grafts down here and they looked great, but the base was infarcted. But this has been attributed predominantly to this amyloid pattern here. Now, in this person's MRI, you can see LGE, late ganglion enhancement, suggestive of this expansion of extracellular volume from the fibrils, and it's more prominent in the base than the apex. I don't know why. I haven't met anybody yet who knows why. If anybody on the phone knows why, please let me know. But this is often what you get is this longitudinal strain pattern that's this cherry on top, or the bullseye appearance. Now, Brett is a man of many talents, and he wrote this paper on how to look at the relative regional strain ratio. So I'm going to give you a few caveats about this. To be a purist, you need to take the average of the basal and mid segments and then divide that over the average of the apical segments. And this 1.5 is what you should look for. And when you don't do that, you can get a lot of mimickers. Another caveat is that what he has taught me is that not all strain is created equal. Right? Different labs have different types of strain, and this is also a challenge if your institution has one vendor. It's not just so perfect that you can go across vendors. These are ones that were cherry on top bullseye mimickers. This patient thought to have it, but he was found to have apical HCM, which is the opposite of what you would expect. You would expect that the apex is not as heavily contractile, but this is something that you should be careful of how you draw your curves. This is another one that was found to be in pericarditis. And here's another one that we often see sometimes in the setting of transplantation. And this is IVUS of what the arteries look like. So you can have a lot of these mimickers that come along. Now, echo also helps in therapy. And as we've learned, we have to figure out the issue with the proteins itself. But there's also this element of heart failure that we need to treat. And this is where echo comes in handy. There's a lot of mechanical considerations, a non-dilated cavity, a thick LV, decreased compliance. Let's talk a little bit more about this overall low output, increased pressures. One thing that I learned about from the talk yesterday is that I was paying attention to a lot of times these follow-up studies for the 2 millimeter decrease in septal thickness, the improvement in EF as you follow therapy in patients with AL. I was intrigued to hear that there was more discussion about the NT-proBNP. Nevertheless, I think we need to keep an eye on the EF and the septal wall thickness, whether you have progression or response. So I'm going to go back to our Jamaican lady because I learned a tremendous amount from her, and will do my best not to say her name. Now, the treatment, this is the treatment that she went through early on in 2012. Bortezomib, dexamethasone, and then she transitioned to bortezomib every 2 weeks. And with that, her EF continued to improve. Then at some point, she got a DVT. At some point, she got a PE. And at some point in May, she developed this chest burning sensation. She was found to be an AF, and she was scheduled for a TEE cardioversion. And this was her transesophageal echocardiogram. And to orient the non-cardiologists around here, this is her left atrium. This piece-looking sign here is her aortic valve. And this is, I'm sorry, this is not her left atrium. This is her left atrium. And what we see here is the left atrial appendage and this smoky, gelatinous mass just hanging out here, Well, it turns out that this is not an uncommon finding in the setting of amyloidosis. This one paper by Dali Feng, Dali taught me that when he was at the Mayo Clinic, he did these studies on amyloid patients. And he told me that when he took a normal human atrium and he held it up to the light, it was translucent. But when he took up an amyloid patient and held it up to the light, it was opaque, it was thick, and it looked like the rind of an orange, is what some of his words to me at the time. And I found that very interesting because now I understand why there's such little contractile reserve sometimes, and you can see why a thrombus would hang out here. In fact, thrombi have been found in several different studies, more since then in the setting of amyloidosis. So Our Lady's follow-up, As you recall, she presented in 2011, stabilized her EF, anticoagulated but not cardioverted, and she presented again with chest pain and dyspnea about 3 years ago. And while she just came to the floor, she went hypotensive, she had syncope, she arrested, and despite our best efforts, we were not able to bring her back. And on autopsy, we found that she had developed a large spontaneous RP bleed. A lot we learned from her. I'm going to switch gears from AL to a little bit about ATTR amyloidosis. So this is the case 3 of the Caymanian. And Brett asked why I had a Cayman license. Well, St. Luke's used to have a clinic in the Cayman Islands, and we don't anymore. We've gotten pretty busy. I'm getting looks from my colleagues here, like, how come I'm not part of this deal? And I want to talk to you about the 77-year-old Caymanian. This is a patient who had moderate AS, moderate MR. My blood pressure used to be bad. He had an LAD stent. He had RCA disease. He had more and more fatigue and dyspnea. It was just out of proportion to what was expected on his echo and his CAD. He had class 2 heart failure symptoms. So we thought maybe he has like mixed valve disease, or like, is it his AS? This was his electrocardiogram. You could say his LVH was maybe not as impressive as you expected it to be. This is his echocardiogram. And you get the sneaking suspicion. This was done in the Cayman Islands. And you can see that the apex is moving more vigorously. It's thicker. Remember, we're not to hang out on bright, but you can say it's kind of bright here. And then this patient had this echocardiogram that said, gosh, EF is preserved, it's thick, but this is paradoxical, low flow, low gradient, severe AS. And one of the comments here is VTI is only 15. The mean gradient is only 21. And I'm going to talk to you about this in a little bit here. But I'm going to talk about the shorter case here. This was his MRI. Again, we didn't have pyrophosphate imaging developed as well then, so all we did was MRIs. And this was what some people call fluffy. And I want you to look at some of these numbers here, which is sort of unbelievable. This was the EF, 46%. This is a stroke volume. Now, if you believe that cardiac output is stroke volume times heart rate, this is the output and the index. So one could say, gosh, are you telling me this guy's an ambulatory cardiogenic shock? And these are some crazy numbers that we get often. Well, he went on to have a biopsy that was confirmed with amyloid. He didn't have light chains. He had an abnormal MRI. He didn't have an MGUS. So we decided that he had probably senile transthyretin, and it was felt to be a reasonable prognosis. Went on to TAVR. Well, it was a crazy TAVR. I mean, he acutely decompensated. He arrested. He had chest compressions, epi, but then he recovered. He pounced back. He weaned off of pressors. He's extubated. And the last time we checked out on him 3 years ago, he was hanging out in the Cayman Islands with improved symptoms. So he did well. He made it. And I think Dr. Dorbala has shared some of this work before, that it's not uncommon that in the setting of HFpEF, that as you get older, it's not uncommon for you to see more and more amyloid deposition. And Brett has reminded me many times that this is seen 13% of the time in patients with HFpEF, specifically if you have a thick septum. 6% getting surgical AVR, 16% getting TAVR, 30% with low flow, low gradient AS, and 10% of the time in carpal tunnel. So it's not uncommon that, gosh, maybe the house officers think that I see amyloid everywhere. Now I want to go back to echo a little bit again, because there's 2 arms of therapy, as we talked about, with heart failure and the protein folding. And it really kind of matters if you have HFpEF or HFrEF, right? So HFpEF, I guess we should say, is this preserved ejection fraction or reduced ejection fraction. I want to talk a little bit about HFpEF. And this is a concept I want to talk about here, because this is a challenge, and there's many reasons for HFpEF. But this patient here on the left has an EF of 55, and so does the one on the right. The one on the right has a really thick LV. And on the MRI, wow, these special effects are fantastic. 1 second here. So on the MRI, both EFs were 55. This was a stroke volume on the left. This was a stroke volume on the right. Again, if you believe heart rate times stroke volume is cardiac output, then the cardiac output on the left is almost double that of the cardiac output on the right, despite having a quote unquote normal EF. This is some of what's about HFpEF. There's another patient here. This is a patient I remember clearly. He said, Doc, I'm here because my wife says I should see you. She says I'm short of breath, but I'm not. This was his electrocardiogram. This was his echocardiogram, and at the time we thought his RV wasn't functioning very well. I don't think we appreciated the LV dysfunction as much. We probably said it was preserved EF. The RV was not hunky-dory. And so the EF was 41%. He had significant pulmonary hypertension. His wife was right. He was short of breath. And he went on to have some more invasive studies. And this was his cath. His pressures were high in the RA. His mean PA pressure was also high. And look at this crazy cardiac index. This is a guy who was just walking around completely comfortable. So we diuresed him, beta blockers, ACE inhibitors, and it improved. He felt better. But gosh, he came back in June and he had more dyspnea, more orthopnea. And while his echo on the left was there, you can see his echo on the right suggests that his LV has thickened. He has a larger pericardial effusion now than compared to previously, and even the atrial septum is much more thickened. He had a pericardiocentesis for that effusion. It was found out that he had negative serum light chains, and it was assumed that based on MRI that he had transthyretin. And this is his MRI. This is just a terrible quality scan. Wait till you see Marianna's pictures. They're just gorgeous. All right, that's what they should look like. But again, effusion, thick ventricle, thick heart. So that was another patient that had TTR. Now I'm going to switch pages here for a second and talk a little bit about aortic stenosis. And I know there's a lot of non-cardiologists on board. So if you are a cardiologist and you know this already, my apologies. So how does a cardiologist assess this aortic stenosis? Because I find that a lot of people come up to me and say, gosh, what does this mean? Paradoxical, low flow, low gradient AS. So often we base aortic stenosis on the three criteria: a tight valve, or the valve is so tight that the jet of blood is squirting really fast and really hard. So the way I try to explain it is that imagine that you have 4 or 5 school buses here that all have to get to school at the same time. Certainly not nowadays, all the schools are closed, but all these school buses are trying to get through that one gate really fast, so they have to accelerate, right? This is what we call the left ventricular outflow tract. This is the LV, this is the atrium, and this is the aorta. So this is the left ventricular outflow tract. And let me move on here. Now, the flow in the LV outflow tract should be the flow in the aorta, right? That's the continuity equation. So what is flow? It's really volume over time through an area, what we call pi r squared, which is we all learned in 6th or 7th grade. And then we have this volume, this time velocity integral. So if you take this LVOT area and you divide it by the flows on both sides, you should get the aortic valve area. So we just plug in our handy calculator here. We have a pi, luckily the good Lord makes most LVOTs around 2 centimeters. So pi r squared is just pi. And then here's our LVOT. Now remember before I said, look at that 15. It was only 15. This is even lower, 10. What's a normal time velocity integral? It should be at least 20 to be normal. And here's the aortic VTI. It's about 40. So when you do that, the calculation comes out to AVA of 0.8 centimeters squared. But this only had a peak velocity of 2.4 meters per second and a mean pressure grade of 12. So this is there were some other concerning findings here. We had high this tissue Doppler ratio, which I didn't get into, high left atrial pressures, and a high systolic or really low systolic velocity, telling you something's going on with this ventricle. So this is what the echo report said. The LV function has deteriorated. Aortic stenosis has progressed. The previous mean gradient was also 12, but the valve area is smaller now when compared like a few years ago. It could be a pathologist unclear. It could be ischemic. It could be amyloid. It could be pseudo. Why don't you consider getting calcium scores of valves, get a cardiac MRI for amyloid, valve planimetry, a stress echo, or a TEE. So this patient went on to get an MRI despite having their device in, which we can do now more and more safely. And what we see here is, gosh, this really is a tight valve. When we planimeter, it's about 0.8 centimeters squared. Now, before I show that, this patient did find out to have amyloidosis. He did have transthyretin, a positive PYP, pyrophosphate exam, which Dr. Dorbala is going to talk about, and had a and had an abnormal MRI for that purpose as well too. Interestingly enough, this patient said, you know, doc, I've had these symptoms for about 12 years, ever since I got treated for my prostate cancer. And looking back in a scan from 12 years ago, actually, his heart had lit up with the HDB tracer at that time too. So this was present for some time, and it gives you a true testimony to how long this can be indolent before it picks up on people. Now, should he get a TAVR? Fascinating work by Paul Scully and Cush and Tom and Leon and Marianna, who's on board, and James Moon. You know, they just published this, that they actually have pretty good outcomes. So there was some argument about whether a person with a mean grade of 12 will actually benefit. This would suggest that perhaps we should not just write them off. So echo in the role of cardiac amyloidosis, it can lead to the diagnosis. And things that we have taught people is just remember, quote unquote, LVH in the absence of hypertension may suggest an infiltrative cardiomyopathy, or on echo without voltage on an EKG may also suggest an infiltrative cardiomyopathy. All that glitters is not amyloid. All that is cherry red is not apple green. You have to be careful with longitudinal strain, but please don't throw it away. You need to do it. Don't forget to do it, especially in the elderly with this potential HFpEF, because you may be missing quite a lot of people. And it's important in the management of and prognosis of heart failure, whether you try to treat preserved or reduced ejection fraction. I think I read one of Dr. Dorbala's papers that they use atrial velocities to guide anticoagulation, and then AL, how to treat that disease entity. So Congo red flags, as we like to say, low normal LVEF, low normal EKG, a low level but elevated troponins, a lower BP, that is to say they're orthostatic, or if you now had to de-escalate antihypertensives, low flow, low gradient AS, these are these red flags. And these are the flavors of amyloid that I try to remember myself. I want to take 1 minute to thank so many people. Brett Sperry, partner in crime, Natana, I would say she's our clinical coordinator, but she's our clinical nurse champion. Shehzad and Farah, our hematologists, and then John Eatman in neurology, and of course, pharmacists, the pathologists, the echo, nuclear, MRI department. I don't give them enough ice cream. And that's all I have. Finally, one final shout out here, maybe too early to say, but we've been so pleased with the success that we're going to go ahead and announce next year the second virtual amyloid symposium. And the date, of course, is subject to the pandemics, climate change, and or other acts of God. Thank you.
Dr. Saeed going rogue here and announcing for next year already. All right, fantastic. Well, that was a great overview of echo and amyloidosis and things to look out for, and leads nicely into the next couple talks here that we have today for imaging. So I'll ask Dr. Dorbala to come on and be able to share her screen here. So Dr. Sharmila Dorbala, we're very happy to have her here. She's an associate professor in cardiovascular medicine at the Harvard Medical School and is a nuclear cardiologist at the Brigham and Women's Hospital in Boston. She's the current president of the American Society of Nuclear Cardiology and is an expert in multimodality, cardiovascular imaging, and cardiac amyloidosis. I do have to give Dr. Dorbala a lot of credit for this conference here because the ASNC Society gave a fantastic virtual meeting last month geared towards cardiology fellows over the course of a couple weeks. And so we decided to follow a very similar template that she had for her meeting with this, and it's worked out well so far. So thank you again so much for speaking at this. And she will be speaking to us about nuclear imaging and cardiac amyloidosis.
Thank you so much, Brett. Congratulations to you, to Ibrahim, Saeed, and everyone else who's organized this really amazing symposium on cardiac amyloidosis. These are my disclosures. So let me start with a slide which says, why is it important for us as a community to organize some of these cardiac amyloidosis educational symposium? As you heard just now, ATTR-CMP is not uncommon and a number of patients have it and it's highly underdiagnosed. We looked at this, looking at the CDC mortality death certificate data from 1979 to 2015 and found very interesting geographic differences in reporting of amyloidosis on the death certificates. And you can see some hotspots here in the Northeast. And then subsequently, we looked at the Medicare fee-for-service database. And in about 121,000 hospitalizations, we found a very similar pattern of ICD code-based diagnosis of cardiac amyloidosis with geographic differences. And this is highly interesting because the question is there any regional difference in the amyloid itself, or is it just better detection in these areas? And we believe it's probably the latter. So I just wanted to share with you a very recent publication. This is just out of curiosity. What we did was we looked at Google Trends, which is we try to understand where are people searching for the term amyloidosis. And then we compared it. So this is called the Google relative search volume for amyloidosis in the y-axis. And on the x-axis, you have reported age-adjusted mortality rate per million from the CDC. And what we found was a correlation. And you can see here, states, Massachusetts and Minneapolis, the size of the circle correlates with the population in that particular state. So you can see these are not necessarily the most populous states, but you see Google relative search volume is very high and reported age-adjusted mortality is also very high. So how does this relate to your conference? Thank you for organizing this really amazing conference. And all that this tells us is you need to increase awareness about amyloidosis among physicians, among patients, among all healthcare professionals and practitioners, because it's important to think of amyloid. Once you think of it, then you can get into making a diagnosis. So once again, congratulations on having an excellent symposium, and today is the last day, and you're adding to this. We hope to run this again and see if there's any change, maybe in a couple of years or 5 years from now or something. So coming back to my topic, so nuclear options in the evaluation of cardiac amyloidosis. So if you look at amyloid, what are we trying to image, right? We're looking at the phenotype, whether it's structural phenotype or functional phenotype of patients with cardiac amyloid. And within the structural phenotype, you could look at gross phenotype or molecular phenotype. So radionuclide imaging comes into this area where you're talking about the molecular phenotype of amyloidosis. What about function? Again, there's many techniques, non-invasive techniques to study cardiac function, echo, MR, and others. But when you talk about molecular functional imaging, that is where radionuclide imaging gets into play. So we can image myocardial innervation, we could image myocardial microvascular perfusion, myocardial oxidative metabolism, and more. So one of the first things that's been studied, probably bone avid tracer scintigraphy was first, but MIBG was also studied extensively in transthyretin amyloidosis of the hereditary type. Because as you have heard over the last several days, some of these hereditary forms of amyloid do manifest with neuropathy and cardiac denervation. So here's a study where the investigators showed very nicely that in a patient who has denervated myocardium, there's very minimal uptake of MIBG compared to a normal control. And look at this, prognostically, the heart to mediastinal ratio, if that is less than 1.6, this group of patients had significantly worse outcomes. What about microvascular perfusion? So a number of investigators have looked at microvascular blood flow using invasive angiographic techniques. We looked at it using N30 pneumonia perfusion. And in this study, when compared to hypertensive left ventricular hypertrophy, patients with amyloidosis, including both AL and TTR, you see a significantly reduced resting perfusion, stress perfusion, reduced coronary flow reserve, and reduced coronary flow reserve when it's adjusted for resting myocardial blood flow. So here's an example of a patient who has a very thick ventricle, 18 millimeters, concentrically thick, and this patient has amyloidosis. And here's the perfusion images with N30 pneumonia, stress on the top, rest on the bottom. You can almost see an apparent transient cavity dilation, extensive perfusion defects that are overtly reversible. Look at the myocardial blood flow. Severely reduced. These numbers are much lower than anything we have seen in ischemic heart disease patients, and flow reserve is very, very severely reduced. So this patient had AL amyloidosis, was treated, came back 6 months later, and you can see improvement in perfusion, and you can see there's still residual perfusion defects, but overall myocardial blood flow increased even within 6 months at a time where you know that the amyloid fibril has not resolved, suggesting that this could be improvement in the so-called myocardial toxic effects of the circulating light chains. So coming now to specific imaging of amyloid itself, what are the imaging targets? So here's a schematic of a heart with cardiomyocytes and extracellular space. With hypertensive heart disease, you have myocyte hypertrophy with concomitant probably ECG voltage increase. On the other hand, in patients where the wall thickness is related to infiltrative process, particularly with infiltration by amyloid fibrils, then what you would notice is that there's left ventricular and right ventricular thickening that can be nicely imaged with MRI and with echocardiography. Extracellular space is expanded massively by infiltration, and this is beautifully imaged by MRI. But more importantly, what's causing this expansion of the ECV or thickening of the myocardium is amyloid fibrils. And radionuclide tracers, both SPECT and PET tracers, are extremely helpful in targeted imaging of these amyloid fibrils so that we can detect this. One last point on this slide is that in patients with amyloid, a low voltage ECG has been described, but as you may have heard, this is not a very sensitive feature, therefore, or specific feature. Therefore, don't wait to see a low voltage ECG before making a diagnosis. So what about a comparison of biopsy? When you think of infiltrative heart disease, we always think biopsy is the gold standard. So this is an autopsy section of a patient who died and had light chain form of amyloid. All this blue-green is sulfated algin blue stain showing amyloid. All the yellow is cardiomyocytes. So depending on where you do a blind endomyocardial biopsy, you can imagine a biopsy finding being completely normal to a biopsy showing extensive amyloid. And this could be particularly a problem if your goal is to detect early amyloid deposition before the increase in wall thickness, before there's extensive amyloid infiltration. Of course, in addition, it's invasive. Quantitation is not possible because you're sampling a very small portion of the heart. This cannot be used to assess response to therapy. And finally, changes in structure or changes in amyloid may lag behind changes or improvement in organ function for assessment of response to therapy. The big advantage of molecular imaging is that not only can you image the whole heart, but you can image the whole body. And when you're talking about a systemic disease such as amyloidosis, it's important to evaluate the entire body amyloid burden, and radionuclide imaging, particularly with molecularly targeted tracers, do a good job. A number of amyloid PET tracers are out there, originally developed for imaging Alzheimer's disease, but have been all studied in cardiac amyloid. These tracers are proven to be quantitative. They're the only tracers that are currently available for imaging AL amyloid in the heart, and they can all detect organ amyloid deposition. I'm showing you a list of some of the early studies. There are many more studies published on this after that. However, each of these studies has a small number of patients at this point. One recent study, which is online on JACC Imaging, published ahead of print, looks at C11 Pittsburgh B compound for the detection of cardiac amyloidosis. And as you can see here, AL compared to controls, this was 100% specific and 100% sensitive. This is not true just for PIB, but all other tracers seem to be much more avid for the light chain form of disease, the PET tracers, compared to TTR. They performed very well even with TTR amyloid, and you can see retention index had similar performance. On the right, you see a time activity curve. This is activity in the blood pool, and these solid lines are activity in the myocardium. AL shown in the orange, ATTR shown in green, and you can see here control hypertrophic hearts shown in blue. It's very important that imaging at an earlier time frame be performed, because that's when the myocardial curves are very distinct and separate. And if you wait very long, it's possible that these tracers may not be able to distinguish amyloid from controls very easily. This is just to show you some of our work showing whole body imaging detection of pulmonary amyloid deposits in the salivary glands, tongue, and including spleen, kidney, and other organs. Kidney is not as well imaged with this tracer. as the heart, lungs, salivary glands, and other organs. We've also looked at this in identifying pulmonary amyloidosis. So here's recently published data suggesting that in patients who have visually intense uptake of the tracer in the lungs, these patients by various quantitative metrics all demonstrate evidence of retention of tracer in the lungs. On the top here is C11 acetate imaging, looking at blood flow in these patients. And look at the lungs, there's no retention of radiotracer. The same patient on the same day underwent a florbitapir study, and you can see intense pulmonary uptake by florbitapir, suggesting that this patient actually has pulmonary AL amyloid. And this is the first time we are able to show that non-invasively, using a molecularly targeted tracer, we can diagnose pulmonary amyloid. More recently, we have a paper which is in press. Sarah Cuddy has done this work showing that using florbitapir in conjunction with ECV on MRI can make a diagnosis of early cardiac AL amyloid in patients where the wall thickness is normal, cardiac biomarkers are not elevated. So here's data showing that in patients with this active non-cardiac AL amyloidosis, they have very low retention index compared to active AL cardiomyopathy defined by release of cardiac biomarkers. But within this group, you see half of these patients have abnormal retention index in the values that are consistent with those with cardiac biomarker release. Same thing with ECV. Again, you can see that the ECV in cardiac patients is much more expanded, but within the so-called non-cardiac, a significant proportion of them have ECV that's not normal. But in this context, you see that longitudinal contraction is still preserved in majority of these patients, again confirming that this early phenotype of cardiac AL amyloid is apparent on molecular imaging methods before there's a functional change in longitudinal contraction by echocardiography. So shown in a different way, on the top are the patients by conventional diagnosis of cardiac AL, retention index, ECV, GLS, cardiac biomarkers, all of them are abnormal. On the bottom, you can see abnormal in the frequency of 90 to 100%, whereas in the bottom is our non-cardiac group, normal wall thickness, no biomarker release. And you can see the so-called non-cardiac group, substantial abnormalities in retention index and in ECV, but global longitudinal function is minimally impaired. Again, suggesting that there is an early phenotype that we are not able to detect by the current criteria where imaging may play a role. So focus here on the right two columns, active cardiac amyloid and active non-cardiac amyloid. These are both patients categorized clinically and by wall thickness criteria as non-cardiac AL amyloid. When you look at targeted molecular imaging, clearly this patient has a lot of AL amyloid in the myocardium compared to this patient who does not have AL in the heart. So again, this is how molecular targeted imaging may help us identify early disease phenotypes at a stage where they may be more amenable to therapy. Now switching gears to cardiac SPECT. So bone avid tracers, PYP, DPD, HNDP, are widely used for imaging. These have been studied since the early 1980s, but more recently increasingly being used. Why do these tracers show cardiac ATTR? There are a number of proposed binding sites for PYP, DPD, or HMDP, calcium deposits, myofibrils, macromolecules, and all of these, and a number of amyloid fibril components as well studied. But the bottom line is at this point, we do not know what exactly these tracers are binding to. This is how the images look. You can take a partial whole body image as is typically done with DPD or HMDP. And on the bottom, you have chest images, planar and SPECT. We prefer to perform SPECT CT imaging with attenuation correction in our institution. And here you can see grade 0, no myocardial uptake, grade 3 myocardial uptake greater than rib uptake. Grade 1 is faint uptake in the heart, less than rib uptake. Grade 2 is equal to rib uptake. So using these criteria, early studies suggested that this technique is very useful with a high sensitivity and specificity to identify ATTR cardiac amyloidosis, in this study even AL amyloidosis. The largest study on this topic comes from Julian Gilmore, a number of authors on this. This was a multi-center study. Marianna Fontana's group published this in collaboration with a lot of other sites. And the results of this focus on the rightmost bars. In a patient who has heart failure with typical echo and CMR features, and if AL amyloidosis is excluded, in that group of patients, grade 2 or grade 3 myocardial uptake of bone avid tracer in the heart is 100% specific for ATTR amyloidosis compared to biopsy. However, the sensitivity is only 72%. But the key is, if your goal is to avoid biopsy to make a specific diagnosis, then this is what you're focusing on. The other metric that's been studied is heart to contralateral ratio. And here you have a region on the contralateral chest, on the heart. This ratio 1.9 suggesting amyloid and 1.0 suggesting no amyloid. Work from Dr. Sabi Bokhari and colleagues from Columbia University suggested that this threshold of 1.5 nicely separates AL patients, which are less than 1.5 HCl ratio, from ATTR patients who have a ratio of higher than 1.5. Remember, in this particular publication, they did not study the value of this HCl ratio to diagnose amyloidosis. This was all patients with documented amyloid. The ratio was used to separate AL from ATTR. In a subsequent multi-center study, Adam Castano and Sabi Bokhari and others looked at the HCl and visual ratio and the diagnostic accuracy. Again, focus on this 100% specificity, because that is what you need to avoid biopsy. So the visual score had 100% specificity on the 3-hour images, and the HCl ratio had 100% specificity, or 97% specificity at 1 hour. So if you go by the goal of avoiding biopsy, this may be the appropriate protocol. More recently, there was a publication in CircCV Imaging from Pittsburgh, Dr. Prem Soman's group. Ahmed Masri was the first author. And what Ahmed showed in his study, again, if you look at the visual grade, 3 hours, grade 2 or grade 3, specificity is 99%, nearly 100% at 3 hours, and less so at 1 hour. Again, this is an ongoing debate whether scanning should be performed at 1 hour or 3 hour. Clearly, the 1 hour has advantages of being a rapid protocol, so patients don't have to stay as long. And for the most part, 1 hour is probably sufficient if the patient has documented amyloid. But if you're trying to apply this technique to a group of patients with suspected amyloid, where you have no proof of amyloid, then the specificity is maximal at the 3-hour time frame, suggesting that if your diagnostic accuracy is similar at 1 hour and 3 hour, I know that Brett Sperry also has a paper that's coming up suggesting very similar findings, which is diagnostic accuracy is not different between 1 and 3 hours, but the specificity of the test is better at 3 hours in the Prem-Soman paper, as well as in the previous multi-center paper, again suggesting that perhaps the 3 hours what we should be using. Brett also performed this very nice work with Mays Hanna and Y.L. Jaber and others at Cleveland Clinic, showing that if you look at the apical sparing pattern on global longitudinal strain, you can see that there's a similar pattern with PYP on SPECT-CT imaging, and that this pattern was prognostically significant. This is important because what are the parameters that prognosticate these patients? If you look at bone scintigraphy data from the London group, Marianna Fontana's group, suggesting that patients without cardiac amyloid have better outcomes compared to patients with cardiac amyloid. However, grade 1, 2, or 3 did not really differ in terms of outcomes. What about the multi-center study published by Adam Castano? Again, you see HCl ratio less than 1.6 had much better outcomes compared to more than 1.6, but you really did not have a gradation. No amyloid versus amyloid, but there's no gradation further. So quantitative SPECT imaging is one where we are very interested now because it offers the potential of early diagnosis, potential to have more granular risk stratification, and importantly, may provide some clues about evaluation of response to therapy. And all of these become very important now in the era where you have treatments that work better if given early, and treatments, multiple treatments. So you may be able to choose one versus the other. If patient doesn't respond to one therapy, it's important to recognize that early so you could offer a different form of therapy that could be life-saving in a given patient. So quantitative data from the London group, Marianna's group again, looking at perogeny grades 1, 2, and 3 in relation to ECV, and percent injected dose is a quantitative metric that can be measured on SPECT-CT imaging. This is a DPD SPECT-CT study showing that as the ECV increases, the percent injected dose value increases with a linear relationship. And similar data in a small number of patients, about 10 patients, again, showing linear relationships with cardiac SUV max and peak in relation to perogeny score. So there's much more information coming out about quantitative SPECT and SPECT-CT that we all look forward to. So key points on these scans, they are currently used for diagnosing advanced cardiac amyloidosis. However, early disease can be diagnosed. Remember, bone avid scintigraphy does not exclude AL amyloidosis, and MDP, which is widely used for bone scanning in this country, does not exclude ATTR cardiac amyloidosis. So if it's a negative MDP scan, you suspect ATTR, please proceed with a P/P image. Then last point is there's a low sensitivity of bone tracer scintigraphy for certain hereditary forms of ATTR that is now increasingly being recognized. Here's an example of how we are currently using this. Advanced amyloid on cardiac phenotype by echo or MRI, P/P SPECT-CT showing intense uptake. Unfortunately, this patient did not survive, and you can see extensive amyloid deposition. Contrast that with this patient who has a hereditary TTR gene mutation. She wanted to participate in a clinical trial, normal cardiac function, yet P/P imaging detected extensive uptake in the heart, suggesting that she already had ATTR cardiac amyloid. Here's an example of a patient who had a negative P/P scan, classic features on echo and on MRI, suggesting cardiac amyloid. This patient went on for further testing and was found to have light chain form of amyloid disease. Floor beta pair confirmed presence of amyloid in the heart. Here's an example of the patient who had a negative MDP scan, but he was brought back for ongoing symptoms and typical MR and echo, and you can see intense uptake on P/P. And these are the last data that are emerging, suggesting that in certain forms of hereditary TTR disease, the P/P or DPD scans may be negative. One study suggested that this may be related to the so-called fragmented versus full-length fibrils, and full-length fibrils showing negative DPD but positive C11 PIB. Healthy volunteers showing no DPD uptake, and those with fragmented fibrils do show DPD uptake. Another study, again, showing that only about 10% of the patients with this mutation and wall thickness of more than 12 millimeters demonstrated visually positive DPD uptake. So keep in mind, if you're dealing with a hereditary patient, this scan may be negative. I just want to conclude in the last few minutes with this consensus document that was developed by multiple societies. It was an ASNC-led document in collaboration with a number of societies and a number of authors who are active in the field of amyloidosis. So based on these recommendations, a diagnosis of cardiac AL or ATTR is possible by endomyocardial biopsy proof with typing of the amyloid fibril. If not, you need an extracardiac biopsy, and with AL or ATTR, typical imaging features on echo or MRI are sufficient to make a diagnosis. Whereas if you have extracardiac biopsy and abnormal cardiac biomarkers, they are sufficient to make a diagnosis of AL amyloidosis. What about diagnosis without biopsy? That is possible for ATTR cardiac amyloidosis using the criteria that I mentioned before. Grade 2 or grade 3 bone avid tracer uptake, exclude AL amyloidosis, and look for typical cardiac imaging features. This document goes over in detail about appropriate use criteria for the various scenarios that are listed here. In general, patients where the suspicion is for ATTR cardiac amyloidosis are the ones who are candidates for PYP, DPD, or HMDP imaging. Who to test for cardiac amyloidosis? The expert panel in this group felt that patients who are older, particularly African Americans with HFpEF or LV thickening, non-African Americans with HFpEF and LV thickening, low flow, low gradient aortic stenosis, unexplained peripheral sensory neuropathy, known or suspected hereditary ATTR, patients with monoclonal gammopathy or elevated free light chain levels, follow-up of progressive symptoms in AL or TTR, and a number of other conditions where you might consider echocardiography as the first step to look for cardiac involvement. So in conclusion, radionuclide imaging provides an accurate and non-invasive means to diagnose cardiac amyloidosis. It is typically used in conjunction with echo or MR imaging. Appropriate use of bone avid scintigraphy may allow a non-biopsy diagnosis of ATTR cardiac amyloidosis. A high index of suspicion and early diagnosis is key to improve benefit from targeted therapies. Therefore, do consider imaging early on in patients with HFpEF. Standardized algorithms to streamline evaluation of patients with heart failure for amyloidosis are critical. I want to thank my team and the study subjects and funding partners, all of whom have made these studies possible. And I would like to end by thanking Brett again for inviting me to this symposium. Thank you, Brett.
Thank you. Fantastic overview of all sorts of nuclear tracers for cardiac amyloidosis. And we have several questions here in the chat. I think we'll save them to the end if that's okay, so we can move on and have Dr. Fontana unmute herself and share her slides. So I want to introduce Dr. Marianna Fontana. She's an associate professor and honorary consultant cardiologist at the National Amyloidosis Center in the Division of Medicine at the University College London as the director of their cardiac MRI unit at the Royal Free Hospital. She's an expert in cardiac MRI imaging and cardiac amyloidosis, is widely published in the field, as you can see by the references to her work from both of our prior speakers, Dr. Saeed and Dr. Dorbala. It's later at night there in London right now, but we thank you for being with us to participate and to speak about the role of cardiac MRI in amyloidosis. Thank you.
Thank you so much for the invitation. It's a pleasure for me to be here tonight. I hope that my children are not going to come. My husband is meant to be looking after them. And so I will briefly talk about CMR in cardiac amyloidosis. It seems that I cannot advance the slide. Okay, this is my disclosure. And I will start by asking why we need CMR infiltration. Then I will talk about the existing evidence on CMR in amyloidosis. I will continue with some clinical cases, and I will briefly talk about future directions. So why we need CMR in cardiac infiltration? So what we have done as clinicians was initially to try to define cardiac disease by looking at the structure and the function. So, for example, we have defined DCM when we kind of were in front of the late ventricles with dysfunction. And we were defining, for example, hypertrophic cardiomyopathy when there was increase in LV mass with no changes in loading condition able to explain it. But the problem is that we very soon realized that by doing that, we were not very close to the disease actually driving disease progression. And this one is an example of this concept. This one is a 73-year-old lady that was referred to the cardiology with shortness of breath. This was the echo. So the patient had before had an aortic stenosis, and now there was an aortic valve, well seated and well functioning. But the cardiologist thought that the increase in LV mass was disproportionate to the history of the patient. So he referred this lady to a tertiary referral centers with a suspicion of hypertrophic cardiomyopathy. When then we look at the guidelines, in an adult, HOCM is defined by a wall thickness more than 15 or equal to 15 in one or more LV myocardial segments as measured by any imaging technique that is not explained solely by the loading conditions. So here at the tertiary referral centers, a diagnosis of hypertrophic cardiomyopathy was confirmed and the patient was followed up for 5 years. Then on the 5th year of follow-up, the patient underwent a CMR scan, so we think the job done. But actually on the 5th year of follow-up, the patient underwent a cardiac CMR scan for research reasons. So it was just a protocol in patients with severe AS, with previous severe AS. And this was the LAGAD. As you see, there is what we call altogether kinetics, so the blood is black as opposed to gray, and there is extensive LAGAD enhancement. So any cardiologist that sees this picture will report this scan as characteristic of cardiac amyloidosis. So then the patient underwent a cardiac biopsy and a diagnosis of ATTR amyloidosis was confirmed. So why we got this diagnosis wrong in these patients is because basically we didn't have any information about the underlying disease process responsible of the hypertrophic phenotype. And we based our diagnosis just on function and structure. And what we really want is we want information about the underlying disease process, and only histology can give us this information. So the question for this talk will be, can we get closer to histology with imaging and specific cardiac MR? So what is the clinical utility of CMR in amyloidosis? So it is more than 10 years, actually 15, after the seminal paper published by Masira in 2005 in Circulation, that we know that after we give contrast to patients with cardiac amyloidosis, we have a very typical appearance on the images called LAGAD enhancement. So on the left is a normal subject, on the right is a patient with cardiac amyloid, and you can see the difference is striking. So the blood should be gray, like here, and the myocardium should be black. What happens in amyloid is that there's so much amyloid within the, within the myocardium that the contrast goes very quickly out of the blood into the myocardium, and you get this line of subendocardial LAGAD enhancement, and so the blood is black. So after this very seminal paper showing a high specificity for the characteristic reported, several papers came out with not the same specificity, but most importantly, there wasn't any correlation between presence of LAGAD and prognosis. And this one is very odd because LAGAD predicts prognosis in almost every cardiac disease, so why there was no correlation in amyloid? Sorry. So, and the reason is because LAGAD is an imaging technique that is extremely useful and was actually invented to look at focal disease against the normal myocardium. This one is a myocardial infarction. By convention, we decide to display the scar as white so what we do is that whilst we scan, we set a number called inversion time, and we make the scar display as white and the normal myocardium as black. So this one is easy when there is a focal disease against normal myocardium, as in myocardial infarction. But when the whole myocardium is normal, like in cardiac amyloidosis, how do you decide what to know? Because you have to think there is the radiographer in front of the machine that has to set the inversion time to decide what is more disease, but it's extremely difficult when actually everything is disease. So these are two images. You can see mirror of each other, but actually in the same patient. So which one is right? How do you decide which one is right and which one is wrong? So what we did, we compared two types of reconstruction: the magnitude reconstruction that is highly dependent on this parameter, the inversion time that has to be set by the radiographer, and the PSIR reconstruction that is much less dependent on the inversion time. And we compared with what was the gold standard, that is T1 maps done at equilibrium contrast between the blood and myocardium. And what we realized is that when we had mirror image of each other within the same patient, every row here is a patient, actually the PSIR was always right. And why was that? These are inversion recovery curves. On the left is the magnitude, on the right, the PSIR. And the dotted lines are the inversion times set by the operator. So if you see, the blue dotted line will null the myocardium, so will make the myocardium black and the blood bright. But the red inversion time will make the blood black and the myocardium bright. But actually, when we use the PSIR on the right, in this specific case, the myocardium will always be brighter than the blood, in spite of the inversion time set. So the answer here is extremely simple. You just simply need to ignore the images in the magnitude reconstruction and just look at the PSIR. And why I stress this concept? Because at the National Amyloidosis Centre in London, we get referred 1,300 patients with suspected amyloidosis each year. And the most common reason for false positive results is actually that people look at the magnitude reconstruction, do not use the PSIR. So by using the PSIR, we understood that there were three different patterns of late-GAD in amyloid. So no late-GAD, subendocardial legal enhancement, when you see this line of subendocardial enhancement, and when the whole myocardium is bright, we call it transmural legal enhancement. So the first message is that these two patterns are present in both AL and ATTR amyloidosis, so CMR shouldn't be used to differentiate between the type, as illustrated by Sharmila. Nuclear medicine, and specifically bone scintigraphy, is much better at doing this job. But why is it important to use the late-GAD? So late-GAD in MRI is still the cornerstone of all diagnostic algorithm. And in amyloidosis, when you use the PSIR reconstruction, you get very typical appearance. But the problem with the PSIR is that is a pattern that is specific only very down the line. And actually what you want is to diagnose disease early, track disease over time, and to assess changes with treatment. And some of the mapping technique can do that. So with T1 mapping, ECD mapping, and T2 mapping, we can measure these processes, identify early disease, and we can monitor disease progression. So what is T1 map? T1 is a number expressed in milliseconds and is roughly proportional to the water content of the tissue. Water content that can be free water, like in myocarditis, for example, or water bound to large molecules, like amyloid or collagen, for example. So this one is an example of a T1 map before contrast. So say you take the patient into the scanner, 1 birth old, and you get one of these images. And here each pixel represents a T1. So what happens to T1 in amyloidosis? So when you look at other diseases, there is a very marginal elevation of T1 in hypertension, hypertrophic cardiomyopathy, and aortic stenosis. But you can see there's a huge overlap with the normal range. But actually in amyloidosis, both AL and TTR, T1 is sky high. And this one is the typical appearance. The map you've seen before was green. So green is the normal myocardium when you use this sequence that is called Schmolley. In AL and TTR amyloidosis, you start to see all these red flags into the myocardium that do correspond to the amyloid deposits. And the diagnostic accuracy for detecting amyloidosis is very high in both AL and ATTR amyloidosis by using this non-contrast technique. So the temptation is then, can we just get the patient into the magnet, just do one breath hold, one T1 map, and make a diagnosis? So here are 16 different patients with 16 different causes of increase in LV mass. So you should be able to spot the amyloid just looking at the red flags into the myocardium. So can we just do that? The answer is not, because you can see that the diagnostic accuracy of native T1 is very high, with an area under curve around 0.9 to identify cardiac amyloidosis, but we need to bear in mind that we shouldn't miss not even one case of patients with cardiac amyloidosis. So the approach we would suggest is actually to use a very sensitive cutoff to rule out cardiac amyloidosis, and a very specific cutoff to rule in cardiac amyloidosis, but all the patients with intermediate values, you should still give the contrast. And why does the contrast add informations on top of non-contrast images? So this one is a non-contrast map, similar to the one I've shown you before, but just done with a different sequence. And the problem with non-contrast T1 maps is that it's a composite signal.
I am having trouble hearing you, Marianna. Are anybody else having trouble hearing? 1 second, there's a feedback loop.
I hear well.
Yeah, I hear well too.
Can you speak? Hello?
Yes, hello.
Sorry, okay, maybe it was just something happened here. I apologize,
Okay.
I heard everybody else. Sorry.
No worries at all. So the problem with non-contrast T1 is that it's a composite signal that comes from the extra intracellular space. And what we really want in patients with amyloidosis is actually to isolate the signal that comes from the extracellular space, because it's where the amyloid sits. And we can do that by giving contrast, repeating the T1 maps after the administration of the contrast, because we can get an extracellular volume map that is a pixel by pixel quantification of the extracellular volume, that in patients with amyloid is a measure of the amyloid. And why is this clinically important? These are two patients with TTR amyloid. You can see that there is the same increase in LV mass and same systolic and diastolic function. So you may think, or actually, this is kind of same disease stage. But if you look at non-contrast T1 map, you can already notice that the patient at the bottom, the T1 is higher. When you then give contrast on the leg guard, the myocardium seems to be whiter. But actually, if you look at the extracellular volume maps, the patient at the top, 39% of the heart is amyloid. The patient at the top, at the bottom, more than 60% of the heart is amyloid. And what we do with CMR, we actually can reconstruct the image in natural history of cardiac amyloid deposition. So initially, you have a normal T1, normal ECV, no late guard. By getting a bit of amyloid, you see increase in T1 and ECV, but no late guard. And when you increase the amyloid even more, you start to see subendocardial and then transmural leg guard enhancement. And because ECV is a measure of the amyloid, it doesn't surprise that it does correlate with prognosis in both types of amyloidosis, so both AL and ATTR. So I am a cardiologist, so as soon as I see any picture, what I do, I just zoom on the heart, and actually I try to ignore the right ventricle, just focus on the left. But actually, if we resist this temptation and we zoom out, we can see that when we acquire the cellular volume maps for the heart, we can actually see the spleen and the liver. And here are two different patients, and the difference in the ECV and the liver is very noticeable. So here, the spleen and the liver are blue, so the extracellular volume is normal, is less than 30. But here, the spleen and the liver are bright red. This is a patient with a large amyloid load in the spleen and the liver. What we did, we compared the cellular volume of the liver and the spleen to the SAP scan, that is the current gold standard for the measure of amyloid in the spleen and the liver, but is unfortunately available only in 2 centers worldwide. And in a cohort of 500 patients, we found a very good diagnostic accuracy between the extracellular volume and the grade of SAP uptake on the liver and on the spleen. So this is none, mild, moderate, and large uptake, and you can see a quite good correlation. Then when we tested the diagnostic accuracy for clinically significant uptake on the spleen and the liver, you can see that diagnostic accuracy is quite high, with an error in the curve of 0.9 for both the spleen and the liver. But can amyloid be explained by just amyloid deposition? Probably not. When we start to do T2 maps in cardiac amyloid, we started to notice that the T2 was very high. And what is T2? T2 is a measure of the free water, so we use typically T2 in myocarditis. So why T2 was high? So why there was lots of edema in patients with amyloid? So there was edema, but interestingly, there was more edema in AL before chemotherapy than in AL after chemotherapy, and less edema in ATTR. Then we look at histology myocardial biopsy, and we confirm presence of edema on biopsy in the absence of inflammation. So why there was edema? The hypothesis is that the light chain toxicity or very rapid amyloid deposition in AL amyloidosis caused myocardial edema. So T2 tracks a completely different process compared to ECV because it tracks the process associated with active amyloid deposition. And T2 elevation is independently associated with prognosis after adjusting for the amyloid burden, that is ECV. So is amyloid something that once you get it, you're gonna die with it and is gonna be there for the rest of your life? That's what we probably thought 5 years ago, but MRI has really changed this together with nuclear imaging. So this one is a patient with AL amyloidosis, a baseline. You can see from the lega that this one is a very typical appearance of amyloid. The blood is black, the myocardium is bright, and T1 is elevated and ECV is elevated. You can see that 1 year after, the leg is gone, ECV has gone down, and T1 is down. So what happened here is that there is amyloid regression. And we understood by doing CMR in 150 patients with AL amyloidosis undergoing chemotherapy that amyloid regression is a very common phenomenon happening in 50% of the patients that achieve a very good partial response or complete response. That is basically, in more simple terms, a very good response to chemotherapy. But what about myocardial perfusion? So the way we look at myocardial perfusion with CMR is that we look at first-pass imaging, first-pass perfusion imaging, so when the contrast comes into the myocardium, and we compare the normal myocardium versus segments with reduced myocardium. And for example, here you can see a dark perfusion defect here compared to kind of normal myocardium here. So this is easy, so we can just look at the myocardium and see what is less perfused. But what happens again when the whole myocardium is bright, when the whole myocardium is diseased, when you've got nothing to compare your segment with, because everything is diffusely reduced. We can't look at it with first-pass perfusion, but we can do it by using a myocardial perfusion maps, that is a pixel-by-pixel quantification of the myocardial perfusion. And when we added myocardial perfusion map to the techniques I've shown you before, what we notice is that with high amyloid load, there's a massive reduction in myocardial perfusion. This is very similar to what Sharmila showed with nuclear medicine. So what happens with amyloid deposition, there's capillary disruption, there's infiltration of the vessel, there's low cardiac output, and everything contributes to reduced myocardial perfusion. But what is the clinical application? So when we think, when shall we use cardiac MR? So the two main questions are, if I've got a patient with systemic amyloidosis, is there cardiac involvement? And the other main question is that if I've got a patient with an hypertrophic phenotype, is this cardiac amyloidosis or is this something else, like hypertension, HOCM, Fabry, aortic stenosis? So I will go through a few clinical cases to explain actually how we use cardiac amyloidosis, cardiac CMR in clinical practice. So when we have the question of patients with systemic amyloidosis, is there cardiac involvement, you have mainly two different scenarios. One is a patient with no ATTR, for example, with polyneuropathy or TTR mutation carriers. And here you could just use bone scintigraphy because it's extremely sensitive and specific for ATTR amyloidosis. But for example, in patients with systemic AL amyloidosis, DPD scintigraphy is really very marginally positive in only 50% of those, and 50% will be completely negative. So here, you definitely should use CMR. What about patients with an hypertrophic phenotype? In patients with an hypertrophic phenotype, I think CMR has got a primary role because it doesn't just tell you is cardiac amyloidosis or not, but it gives you the whole spectrum of different reasons for increasing myocardial mass. So I will now go briefly through a few clinical cases to actually show you how the nuclear imaging and the CMR do integrate very nicely into the clinical algorithm of this patient in daily practice. So this one is a 75-year-old gentleman with shortness of breath. Echo showed a symmetric increase in LV mass, and there's no plasma cell dyscrasia. So this one is the DPD scintigraphy, and this would be probably classified as a grade 2. There's no MGAS, so is ATTR amyloidosis, yes or not? And the answer is yes, because as shown by Sharmila, if you've got a grade 2 to 3 cardiac amyloidosis without plasma cell dyscrasia, you can just use bone scintigraphy and make a diagnosis of cardiac ATTR amyloidosis without the need of a biopsy. What about this case? 70-year-old gentleman with shortness of breath, edema. Echo again showed an increase in LV mass, but this time the patient has got an MGAS. So we did a DPD scintigraphy, and there's a very low degree of cardiac uptake, probably classified as grade 1. We also did a cardiac MR, and this one is characteristic of cardiac amyloidosis. So does the patient have cardiac ATTR amyloidosis? And here the answer is not, because here there's a suspicion, the DPD is only grade 1, there is a plasma cell dyscrasia, so you need to do a specialized assessment. In this case, we did a CMR, then a fat biopsy that confirmed systemic AL amyloidosis. The vast majority of patients with cardiac AL amyloidosis will have, almost all of them, a positive CMR in the presence of either no cardiac uptake on the DPD scintigraphy or very low cardiac uptake. Third case, 60-year-old gentleman with shortness of breath. Echo showed increase in LV mass, and the patient doesn't have an MGAS. So is this cardiac ATTR amyloidosis? We did a DPD scintigraphy, there's no cardiac uptake. And then we did a cardiac MR that showed the typical appearance for hypertrophic cardiomyopathy. And if you again look at the algorithm that was published in 2016, there's a suspicion based on the echo, but there's no cardiac uptake on bone scintigraphy. There's no MGAS, so the probability of cardiac amyloidosis is very low, and the CMR gave us the right diagnosis. So now I will go through a few kind of cases, but just in the form of imaging. So remember what I told you about late GAD. Should you use the magnet reconstruction or the PSIR reconstruction to actually make a diagnosis? So these one are two mirror images of each other in the same patient. On the left in the magnitude, on the right the PSIR. Has the patient got cardiac ATTR amyloidosis? And the answer is yes. Just ignore the magnitude. Look at the PSIR. The blood is black. The myocardium is white. This is typical for cardiac ATTR amyloidosis. Another case, magnitude on the left, PSIR on the right. Does the patient have cardiac amyloidosis? Again, ignore the magnitude, just look at the PSIR. There's a beautiful nulling of the myocardium. So the myocardium is black, the blood is gray. This patient doesn't have cardiac amyloidosis. This is just a normal late GAD. Third image, magnitude on the left, PSIR on the right. Does the patient have amyloidosis? Again, the answer is yes. Ignore the magnitude, look at the PSIR. The blood is black. The whole myocardium is white. Again, typical appearance of cardiac amyloidosis. Last example, here's a bit more complicated. Again, two mirror images of each other, which one is right? This time you don't have the PSIR. Some of the scanners do not have the PSIR. And so what do? These one are two magnet reconstruction. So what you should do, you should run a TI scout. And you need to look for the bit of the myocardium that is nulling first. And if you look carefully, you can see that the mid-myocardium is the bit of the myocardium that nulls first. Again, look carefully, you see the black appears sooner here. This means that the mid-myocardium is the bit with the lowest T1, so should be bright on the late-cut. So this one is right, and this one is wrong. So the patient doesn't have cardiac amyloid, but is probably hypersensitive heart disease. So this one is a patient at baseline, and this one is the same patient 1 year after. Is this regression or progression? T1 has gone up, late-cut. Now there is what we call aldogalmium kinetics. You see that the blood is black, ECV has gone up. So the patient is progressing. This one is another patient. Baseline 1 year after. Is this regression or progression? Here is regression. T1 has gone down. Late-cut has normalized. ECV has gone down. Is there amyloid in the liver and the spleen? Yes or not? The answer is not. The liver and the spleen are nicely blue. Is there amyloid in the liver and the spleen here? Yes or not? The answer is yes. You see that ECV is almost close to 100%. There's a large load of amyloid in both the liver and the spleen. So this one is what we use CMR for in clinical practice, but what are the future direction of CMR? So what we need to keep in mind is that what we really want from an imaging technique is to make a diagnosis, is to stratify the prognosis, is to track changes over time. But what we really want is to be able to track changes over time. By doing so, guide treatment strategies and doing that, changing prognosis. And this is what happened with T2-STAR technique in patients with thalassemia. By introducing MRI with T2-STAR, we changed the prognosis of the patient because we could guide better treatment strategies at the individual level. So this is where we want to go with CMR. We are not there, but this is where we would like to be in 5 years' time. And also what we learned from CMR is that amyloidosis is not just about infiltration, but there are several different mechanisms that actually contribute to disease progression and do affect changes prognosis. And what with CMR, we can track all of these different mechanisms over time. But we also need to bear in mind that there will always be more of what we would like to see. And when we introduce a new technique, there will be ebbs and flows in the reporting pattern, but the hope is that with time, we will become more accurate by using the technique. So in conclusion, structure and function is not enough, and the clinical impact of CMR is that we can image the disease substrate. We can visualize the disease and phenotype diseases with late-cut, so it's fundamental for diagnosis, but actually with mapping, we can understand disease processes and measure myocardial processes over time. So shall we just use CMR in all patients? The question is not what is best imaging modality, but actually which is the most useful and appropriate for each step of the diagnostic pathway. Thank you very much for the attention.
Great, that was fantastic.
Yeah.
Wow, 3 great talks. Thank you all for coming on. And so we will we'll open it up for questions now. And we have some good questions in the chat. Most recently is, will these recordings be available later for review, which is, the answer is yes, hopefully, and everyone's been asking us that all week, and we've been hesitant to say yes because we wanted people to listen in live. But yeah, these should be all available at the same on the same website, the kcamyloid.com website, probably within a week or so. I can start off with questions, and there's some that are specific to each speakers, and then there's some that are more overview. Actually, first thing I want to say is to Dr. Dorbala, you know, I think one of your initial slides where you did that study where you looked at the map of the United States and compared kind of a heat map of 10 years ago, and then what has been most or more recent. You know, one of an impetus for us to do this study, or to do this symposium in Kansas City specifically, was because if you look at the area right around where we are, it stays in the blue both times, 10 years prior and then now, which means that there has not been a major increase in the diagnosis rate of amyloidosis in our area. So we hope that that doing this and doing other similar programs locally will help us here in the area. So thank you for publishing that. I've used that slide. I've used that slide and outlined my states before.
Brett, I will credit you and your entire group, Ibrahim, Saeed, and the rest of the amyloid group at Kansas for changing this map, which we hope we will repeat in 5 years and hope to find a much more homogeneous map throughout the country. So thanks to Kevin Alexander for doing this work, and you're definitely changing the map, I can tell you that.
Thank you. So one question that really applies to all imaging modalities here is, and it's been touched upon a little bit by each of the speakers, but I'll just open it up. So how do you follow patients? We'll start with AL. Dr. Saeed, why don't you start first as far as echo, MRI, both, and then we'll hear what the other speakers have to say. And then we'll talk about TTR, because that's another question. How do you follow patients' PYP scans over time when they're on treatment?
You know, that's a great question, because I'm not sure that, I think often our experience has been, it's clinically, like, how are they doing, unless they see like they're not doing from a heart failure perspective. So often the echo in this situation is used to help guide therapy. You know, gosh, what is their edema doing? What are their pulmonary pressures doing? What are their filling pressures doing? I think it all depends on a case by case basis for the AL group, and also for the transthyretin. At this point, it's not as much about diagnosis as it is management of therapy.
Mm-hmm. Yeah, and you know, oftentimes these patients get admitted to the hospital, and there's, you know, there are guidelines out there that if patients have a decompensation, you should reassess their LV ejection fraction, and we do sometimes with these folks, especially the ones with ATTR, and you don't really see much change in their overall pattern. Dr. Fontana, what are your comments on AL, following patients, frequency of repeat echoes or MRI in an AL type patient, and with respect to therapy?
Thank you for the question. So what I think is extremely useful in kind of clinical practice is, of course, the free light chains to assess the response to treatment in terms of chemotherapy treatment. Then the NT-proBNP is extremely useful, because it very soon comes down once you get a cardiac response. And in terms of imaging, what we do is echo every 6 months, although very rarely we see changes. And we think that the global longitudinal strain is definitely the most sensitive parameter to track changes over time. But again, probably the signal to noise ratio is not optimal. We do CMR every year, but I wouldn't do a CMR early than 1 year. CMR is quite relevant in patients where is borderline the response, and you wonder if you actually give more treatment or not. And actually CMR is extremely useful to tell you if you've got fat accumulation or not of amyloid, or actually the patient is progressing with that at a degree of hematologic response.
Do you do CMR at the same time as the echo, or do you kind of alternate them every 6 months so that?
Yeah, so we do the echo every 6 months and the CMR only at 1 year, basically.
And for Dr. Saeed and Fontana, what about a first cardiac test in a patient who has AL amyloidosis that is not necessarily involving the heart? So you have a patient who's been diagnosed with renal AL amyloidosis or another organ, GI, and they have not had a cardiac evaluation before. Do you think echo to start with, and then if there's a concern, go to MRI, or echo and MRI both, or just skip the echo now because we have so much extra information from the MRI and only do the MRI?
You know, I'll defer to Marianna on this one. I think I know what she does, but I want to hear what she says, and then we have a caveat for our side, but I'll let Marianna speak first.
So what we do is that, again, NT-proBNP is extremely useful. If the NT-proBNP is completely normal, the negative predictive value of NT-proBNP is very, very good.
Mm-hmm.
Then echocardiogram. An echo is characteristic. If it's characteristic, you have an answer. We like to confirm it with MRI in where we can, when there's no renal failure, but the patient doesn't have contraindication. But if you have elevated NT-proBNP, a characteristic echo, you can definitely stop there. It's important to understand that the negative echo doesn't mean there's no cardiac amyloidosis, because 24% of patients with the negative echo actually do have legal enhancement on CMR.
Mm-hmm. And I think that's, you bring up a type of patient that's challenging to know what to whether you need to image or not with CMR, and it's also in the chat here that you know, if you have a borderline type of patient, I mean, a lot of these echoes in patients with renal amyloidosis are really borderline. You know, they have maybe stage 4 diastolic dysfunction, or they have a septal thickness of 1.2, and then, you know, they're going to be started on treatment, anti-plasma cell treatment anyway, so MRI would not necessarily be helpful to decide whether they need to be treated or not, but it may be helpful for prognosis and to know whether or not the heart is really involved, you know, and obviously NT-proBNP can be high in patients with renal failure, so that sometimes is a red herring there.
Yeah, and there is a question on the chat: how will the knowledge of cardiac involvement change the management?
Mm-hmm.
Actually, it does, because from, at least in my institution, for example, they wouldn't perform upfront stem cell transplant with cardiac involvement, and with extensive cardiac involvement, then they would, for example, give Velcade as inpatients for the first few doses, and then discharge that patient because the risk is higher. So this will also depend on kind of the decision of the hematologist, but absolutely risk stratify the patient so significantly.
So, you know, I was waiting to hear her answer, because one of the things issues that we have at our institution is that we haven't as well T1 mapping package as well. That's one issue for us. And I think another issue that's very common in many places in the US, that apparently when I spoke with you all at last SCMR in the UK, is this issue with renal failure and using gadolinium-based contrast agent. And we've still been very squeamish to do it. I think it's probably okay, but so there's been a lot of hesitancy to do the MRI for that reason. So that's been our challenge.
Now we give contrast to all patients. So the only category where we really don't is peritoneal dialysis, but we would keep contrast in hemodialysis, low eGFR,
mm-hmm.
because also with the newest publication, the risk of NSF, if you use cyclic agent with low risk, is extremely low, and actually make the right diagnosis is quite important. So our approach is that we give contrast to all patients.
Yeah, we're working out with the legal the legal department, our consent forms
right now. Country to country, absolutely, but also institution to institution. Yeah. This one is not the approach used by all institutions in the UK.
Yeah. Dr. Dorbala, I'd like to loop you in here for the ATTR patient has a positive PYP scan, and it started on you know, either a silencer or a stabilizer. How do you feel about serial PYP scans? Is there value to that? What are your thoughts there?
Perfect. Thank you. So I can actually tell you the results that 7 experts that were polled for the ASNIC multi-societal document said. This was before the treatments were widely clinically approved. But basically, they felt for ATTR, they felt echocardiography was appropriate to assess response to therapy every 12 months and 24 months for, with an appropriate use rating of 7 and 8. Whereas when the question was every 6 months, it ended up with a maybe appropriate rating. So I think the general consensus by experts is that to look at response to therapy, probably 12 and 24 months is okay. And at 6 months, it's maybe. Whereas when you look at AL amyloidosis, to assess response to therapy every 6 and 12 months were both 6 and 12 months were maybe appropriate with a rating of 5. And the experts felt like every 24 months was appropriate with a rating of 7.
Interesting. Well, there were several questions here about the nuclear bone scintigraphy, PYP, DPD, planar versus SPECT, and you did highlight some of this in your talk. I just want to point people to those multi-societal guidelines or documents that you led that were published within the past few months here that really do go over a lot of this and is very helpful for those who are starting PYP scanning or trying to get more into it or knowledgeable about it. Can you just make a few comments about planar versus SPECT, and in this day and age, is it okay to just do planar imaging on people, or do you need at least the capability to do SPECT at your institution if you're going to be doing these types of scans?
Yeah, that's an excellent question, Brett. I'll start off with one point saying that most institutions, at least in this country, do have SPECT technology. Planar only is old technology. I don't believe many institutions in this country are using scanners which can only do planar imaging. So most cardiac imaging is SPECT clinically. Having said that, would you use planar or SPECT? I believe, as I know, and others do, SPECT is important. In fact, SPECT is essential before making a definitive diagnosis of TTR based on bone avid cardiac scintigraphy. You do need to look at the SPECT images to make sure that the uptake is in the myocardium and is not in the blood pool. In fact, we at our site are using SPECT-CT because SPECT-CT makes it easier. We've always used SPECT-CT for the last, I want to say maybe 10 years now. We've always used SPECT-CT because it makes it easier to delineate myocardial cavity, blood pool uptake from myocardial uptake. So I would say SPECT is essential. It helps in ensuring its myocardial uptake and in separating out blood pool from myocardium with SPECT-CT. Now, is there a role for planar? So some people argue that when the scan is negative, particularly if you do not have SPECT-CT, in those cases, planar imaging may be easier to look at to say there's no cardiac uptake compared to SPECT.
Thank you. And we have some, I've heard from some people that do have the ability to do SPECT imaging in the US, but don't do it routinely or don't have difficulty getting camera time. And yeah, I think there are a lot of protocols out there where you only do SPECT if you have any degree, grade 1, 2, or 3 of cardiac uptake. Another question that has come up, and maybe I can have you speak about this, Dr. Dorbala, is just the question of why does PYP, or why do these bone tracers take up in have uptake in ATTR but not in AL, and then is all ATTR created the same as far as different mutations being able to light up with these bone tracers?
So again, excellent questions. The tracer is taken up by AL and ATTR both. It's just that the intensity of uptake is much higher in ATTR compared to AL. So it's not that AL does not have uptake. They can be negative in AL, yes, but some patients with AL do show uptake, which is typically low grade, but on occasion we have seen grade 2 or grade 3 uptake of PYP in AL patients, which I believe is less common. Most common is grade 0 or 1. Why is there uptake in the heart? As I showed you in the slide, I think we do not know exactly what these tracers are binding to, so we can't be certain of why there is uptake. What was your other question, Brad? Oh, about the mutations. Okay, yes. Sorry. So the mutations, I think there's one publication, I shared with you 2 publications. One is the V30M mutation, where they showed using DPD compared to C11PIB that in patients with fragmented fibrils, you do see DPD uptake in the heart. In patients with what is called full-length fibrils, DPD uptake may be negative when Pittsburgh B compound, C11PIB may be taken up. The other publication that I have seen is with the mutation, which is, sorry, it's on my slide. Can I pull up my slide? I'm blanking on the name of the mutation, but basically that mutation was described by the Italian group, Claudio Rapezzi's group, where they showed that DPD uptake is only about 10 to 12% sensitive in that specific mutation. And most patients were negative, even though the wall thickness was more than 12 millimeters, which we would think in a gene positive patient indicates cardiac amyloid.
Mm-hmm. Great. Dr. Saeed, I'll throw to you for a few questions here. You need to unmute.
Questions so far, great questions. Let me ask the other, my co-panelists / the experts. Let me ask them a few questions about the role of endomyocardial biopsy, or do you guys still do it there, and in what situations do you do it?
So I can start. For the National Amyloidosis Center, really almost the only situations where we do it is where there is cardiac uptake, DPD grade 2 or 3, on DPD scintigraphy in the presence of a plasma cell dyscrasia with no peripheral biopsy that is positive, because in that case could be both AL and ATTR. So what we do it for is not to look for amyloid, but actually for the typing. Because I think that now with a combination of CMR and bone scintigraphy, you can really diagnose cardiac amyloidosis in the vast majority of patients, and actually type it with a combination of the two. The only really class where we still have problems is DPD grade 2 and 3 with a plasma cell dyscrasia, but I would be interested to know what Sharmila thinks about that.
My answer is very simple, ditto. I think we follow the same. We have significantly reduced endomyocardial biopsy. It's only done on a rare occasion. Remember, because of the way the patient's heart is, and Rodney speaks about this and others speak about it, endomyocardial biopsy, although the ventricle is thick, is not without risk in some of these patients. So it's reserved. With all the non-invasive imaging that we have, the reasons for biopsy are very few. And as Marianna rightfully pointed out, we also only biopsy for patients where after all the imaging is performed, if there's still a persistent question about either the presence or absence of amyloid, or more specifically, the type of amyloid.
May I add that I find it very striking when actually quite a few of my American colleagues, they tell me they do perform cardiac biopsy much more. And the problem is that because it's easier for them to get a cardiac biopsy than actually get a cardiac MR.
Yeah, and that's not the case at our institution.
Yes, yes, definitely. I'm not talking about the Brigham, but in the sense, especially in UK, it's easier to get a CMR than an ECG, so we don't have the problem. I've used CMR in the UK, I have to say, but in quite a few centers in US, when I say why like cardiac biopsy is so high, because they say sometimes it's quicker to get a biopsy than actually a CMR. So.
Yeah, in community practice, you know, folks around the area that refer patients, for sure, you know, not having a high quality cardiac MRI, not having access to PYP scans, although those are increasing now. And I think the comments about cardiac biopsy are good. I mean, you know, I made Maz Hanna here a co-host if he wants to chime in, but you know, we do cardiac biopsy, and sometimes, you know, there's a lot of RV hypertrophy as well, and so it's very difficult to get the bioptome over to the septum where you want it to go. You know, it's very small and very thick, and you know, so you often end up going very deep into the right ventricle and very apically, and that is an area that you know, is potentially thinner, and you can perforate in, and so so it is not without risk, but our practice is the same as far as the folks that we end up biopsying.
So I have another question I wanted to ask you. You know, it is not uncommon for older patients to be referred because of some heart failure or for some LV dysfunction for a stress test / rule out amyloid, right? So wanted to ask each of your institutions, what do? Do you get a PET and then a SPECT? Do you, Marianna, do you do a stress MRI? And then how do the gadolinium kinetics work out with your PSIRs? You know, how do you guys handle that? You know, just rule out everything. As older gentlemen, you know?
So we have done lots of stress MRs in this patient, and my personal feeling is that whatever they have in the coronaries, you're never going to see enough, because this patient have got a massively reduced myocardial perfusion that is global, is everywhere, can be a bit patchy in the sense it's not the same, but is a global reduction that can be more severe in some segments, but you will never see, at least in my opinion, with CMR, a perfusion defect that is actually related to the epicardial arteries. So sometimes I think a bit more philosophically, like, if this patient do have epicardial disease, does it have an impact on the perfusion? Because the perfusion is already hugely affected. So I would not even be able to answer to that. So, because there is this, the amyloid destroys completely capillaries in the perfusion. So I don't even know if this, for example, a 3-vessel disease, if you really would have an impact on a massive reduce of myocardial perfusion. But definitely by CMR, you will not see what happens in the epicardial arteries.
Sharmila.
Yes, so we do perform ischemia testing in some of these patients. Basically, a lot of these tests are performed before the diagnosis of amyloidosis. I have very kind of less than a handful of patients that I remember where you do pursue ischemic heart disease evaluation for anginal symptoms in a patient with documented TTR amyloid. It happens because these are elderly patients. We've had some people who have both coronary disease and amyloidosis. However, as Marianna pointed out, it's the same issue, which is microvascular dysfunction is ubiquitous in these patients. How can you tell whether or not a given perfusion defect, as you saw in the case that I showed, where the patient had a CT angio showing no epicardial disease, but they were overt perfusion defects. So it's a real challenge in teasing out what part of the perfusion defect comes from amyloid versus what part comes from epicardial coronary disease. So the patients that we send to PET are sometimes patients who have anginal symptoms, more commonly with the AL type of amyloid. And when these patients present with anginal symptoms, we will perform PET with flow quantitation to look for microvascular dysfunction. Some of these patients do manifest microvascular dysfunction. As all of you may have seen, we have seen patients with anginal symptoms go to the cath lab, have single vessel disease, get revascularized before they know that this patient actually has amyloid, because even after revasc, the patient may have ongoing symptoms of angina and subsequent evaluation reveals amyloidosis. So all of the scenarios are possible, but it's very challenging to separate out epicardial disease from microvascular dysfunction.
Fantastic. And I would just add to that, you know, it's oftentimes in Dr. Saeed knows this, it's oftentimes in the nuclear lab that when I'm reading or when we're reading, we end up picking up amyloid for these reasons. We have someone come in for dyspnea or chest pain or atypical angina, and they have a nuclear scan that MPI that looks non-ischemic, but we kind of review the echo and we see there's some increased LV wall thickness. There may be a decrease in global myocardial blood flow reserve, and we kind of raise the antennas a little bit for amyloidosis and picked it up several times that way. I wanted to, I called out Dr. Hanna here and then we moved on, but I want to get his here for the for comments about biopsy.
Yeah, thanks. Thanks for all the speakers. It was an amazing session today. Sorry, I'm in a Canada sweatshirt, but hopefully the Canadians appreciate it. The comment I wanted to make, what Marianna brought up and Sharmila, about the situation where you have significant uptake on DPD or PYP or HDMDP, whatever you're using, and then you also have an abnormality in the serum free light chains and or an M protein on immunofixation. That is unfortunately not super uncommon, and we have to deal with that, particularly in the elderly. So what I face a lot is an 80-year-old male who comes in with biceps tendon rupture, carpal tunnel, spinal stenosis. He has TTR on his forehead, and you get the PYP scan, it's grade 3. There's no M protein on immunofixation, but the kappa to lambda ratio is mildly elevated, particularly in the setting of renal dysfunction. There is some, you would expect both of them to go up to the same, but the kappa tends to go up disproportionately. So let's say the person had the upper limit of normal is 1.65 on the kappa lambda, and the ratio is 2 or 2.2. You have this 80-year-old gentleman, let's say he's on warfarin for AFib. Technically speaking, there is an abnormality in the upper limit of cutoff for the normal renal function, and you have this DPD, let's say that's grade 3, and you're saying, okay, well, we need to reconcile that with a biopsy. I think that's the tricky part in those elderly people. Now, the biggest concern ever, if we start saying that's okay, is the slippery slope where now you miss AL. Because missing AL is like missing an MI. If we incorrectly diagnose AL as TTR and give tafamidis, that's what I call the double tragedy, where you're not only withholding chemotherapy, but you're giving an expensive drug like tafamidis for the wrong diagnosis. So that combination of some abnormality in the light chains and then a very grossly positive nuclear bone scintigraphy scan is not super uncommon, particularly in the elderly. And I think if there's any question, I think you really need to refer to an amyloidosis center, because you don't want to have a slippery slope where you say, well, it's probably TTR and that's renal dysfunction. That could be the case. And somebody who's an expert in the field may say, you know what, in this particular case, I've run it by my hematologist, we're not going to biopsy with that very mildly elevated kappa lambda. But I worry about that slippery slope. And then what we've seen is AL masquerading as TTR, giving you significant uptake. I mean, yes, 0 to 1 is the most common scenario, but 2 to 3 can happen. Sorry about the long-windedness of that, but Sharmila and I, there's a paper coming out in JACC to address the pearls and pitfalls of, PYP and DPD regarding that situation.
Well, we look forward to that, and I think that it's a very important question, and again, not uncommon. And we often consider less invasive tests like a bone marrow biopsy, fat pad, but then there's all sorts of permutations there, right? If the bone marrow and fat pad are negative, are you done? If the bone marrow does show some small amount of monoclonal protein, but the fat pad is negative, then what do you do? So there's all sorts of permutations there, and I agree, referring to folks that have a multidisciplinary interest in this is a good, always a good choice. So we're going to end there.
Dr. Costa wanted to bring up a point about this.
Sorry. So I was just going to echo what, oh, sorry, there's a bad echo in here. Hold on. So the, I would just echo, sorry for the pun, what Dr. Hanna was saying, that, you know, as a hematologist, we get this question not uncommonly. And you guys probably already know just as well as I do that if the patient has a little bit of renal dysfunction, you know, their kappa, which is a larger, you know, it is larger than the lambda, so they are even more poorly cleared than the lambda. So we constantly get this, well, this patient probably has some sort of, probably has ATTR, but then this ratio is 1.9 or 2 or something. And it's always a struggle in my mind to determine whether or not this is AL or not. But usually I just don't even beat around the bush. I just do the bone marrow biopsy, at least get a Congo red on the bone marrow biopsy, because oftentimes that's enough to say that, you know, in the right clinical context with the renal disease and everything, all of the rest of the data pointing in that direction, this one little thing isn't enough to go in the other direction.
Yeah, and you can definitely weed out some of these patients by going a couple steps further with a bone marrow and or a fat pad. All right, well, thank you everyone for joining in here. This was a fantastic week, and we are relieved for it to be over, but also really excited that everyone was involved and enjoyed this. And so signing off for now, and we'll see if we come back yet next year, but we would like to. All right, take care. Thanks.